Our next presenter is Dr. Krista Lai. She's a pediatric surgery research fellow at Phoenix Children's Hospital, and the title of her procedure is, or her presentation rather, is Pediatric Surgeons' Current Knowledge and Practices of Obtaining Assent from Adolescents for Elective Reconstructive Procedures.
Thank you for the introduction and the opportunity. We don't have any conflicts of interest to declare. So, adolescents develop their decision-making ability as they transition from childhood to adulthood, and participation in their medical care is encouraged by participating in assent discussions as recommended by the American Academy of Pediatrics. In 2016, the AAP released a policy statement that outlined 4 essential elements of the assent discussion for pediatric patients. Number 1 is to help the patient achieve a developmentally appropriate awareness of the nature of their condition. Number 2, tell the patient what they can expect with tests and treatments. Number 3, make a clinical assessment of the patient's understanding of the situation and the factors influencing how they are responding. And number 4, to solicit an expression of the patient's willingness to accept the proposed care. So in this study, we aim to establish pediatric surgeons' current knowledge of AAP assent recommendations and also to define their current practices for assent for elective reconstructive procedures. We sent an anonymous electronic REDCap survey to APSA surgeon and fellow members in North America. In total, we had 220 respondents for a response rate of 16.3%. The majority of respondents practice in academic settings with over 10 years of experience. We also had quite a variety of subspecialty surgeons and fellows responding, with the most coming from chest wall, colorectal, trauma, and surgical oncology. Delving into our survey responses, 88% of respondents are familiar with the concept of assent, and of those 88%, 50% had received formal training regarding informed consent and assent. 92% think that there is a difference between informed consent and assent, while 86% thought that assent is equally or more important to parental permission and consent. We asked specifically about this policy statement from the 2016 guidelines. Parents or other surrogates technically provide informed permission for diagnosis and treatment with the assent of the child whenever appropriate. 47% were aware of this policy statement, while 89% always include adolescents as part of the consent discussion. 77% solicit an expression of willingness to accept the proposed care from the patient. Some of the barriers cited to obtaining assent include patient cooperation and understanding, parental cooperation, procedural complexity, and to a lesser extent, language barrier, time constraints, and surgeon familiarity with assent. We then went on to ask, if an adolescent patient refused to give assent, would you still proceed with the elective procedure? 2% of respondents said yes, because parental consent is legally binding. 55% said it depends and offered free text comments. 6 major themes emerged, and they're shown here with some representative quotations. The first theme is the need for shared decision-making through education and having to discuss further with patients and their parents. Second theme, the potential for negative consequences from not proceeding with the procedure. Third, the idea of medical necessity in that not all elective procedures are truly optional. Number 4, patient anxiety and fear, and trying to figure out if fear is influencing the adolescent's decision. Number 5, patient maturity and capacity to assent, perhaps based on the adolescent's ability to articulate the reason behind their decision at the time. And 6th and last was parental wishes again. So there are some limitations to discuss in this. We acknowledge the low response rate and the idea that responses may be biased to those who are familiar with assent responding. When we put this all together, what does this mean beyond the theory and the thought? Well, we can see here that assent is an area of variation in care, and work can be done to effectively engage adolescents in the assent process. Pediatric surgeons and fellows can be supported through formal training and practical tips, but also through institutional policies that can standardize the process, make it efficient, and to navigate any divergences in legal and cultural norms. So in summary, we've shown that pediatric surgeons are largely familiar with and actively practice Assent. In doing so, we're respecting adolescent autonomy and fostering their shared decision-making abilities as they transition into the consenting role as adults. Thank you very much for your time, and thank you to my mentor for this, supporting me with this project, and I welcome any comments and discussion. Thank you.
All right, we'll start out with a virtual question.
Dr. Pakala asks, what elective procedures are you guys talking about specifically?
So in our survey, we did not constrain the elective procedures. However, we gave examples including NUS procedure for pectus excavatum, intestinal reconstruction for any intestinal diseases. Basically, our definition for elective was not being booked on an urgent or emergent basis.
You mentioned some of the barriers in the survey to obtaining Assent were patient cooperation and understanding. So how do you propose we as pediatric surgeons approach that?
Thanks for the question. I think that is a really important area for us to kind of think about and consider how we may overcome that. I think one important area would be gathering support from allied health, so we can involve the expertise and the knowledge of psychologists, patient care advocates, particularly in cases of chronic or complex illnesses, especially those who have gone through it. They can help the patient navigate that, child life support, social work, and I think if time allows it, repeated visits with the family and the adolescent to allow them the time to figure it out and come back with a decision that can be shared and accepted by all parties.
Just one question, did you, in your study, because clearly you're interested in this, did you find an age where maybe the kids would, be able to do it? For example, I have 12-year-old boys, I can't even get them to take a shower, much less,
Yeah.
Assent for anything, so.
Thanks, that's a really great question. And we actually asked that in our survey. I just didn't have time to put it in my presentation, but the majority, over 70% of respondents, stated that they thought that the right age for Assent is 13. There is literature out there, and however, there, as you have already alluded to, is no consensus on when there is an age cutoff where children and adolescents are ready. It's mainly based on several factors, including their own personal medical experience and journey, as studies have shown that those who have chronic illnesses and have lots of experience in the medical world have much greater capacity than their age would dictate to make those decisions. So in short, I believe it's an individualized decision between the family, the adolescent, and the pediatric surgeon and fellows.
All right, thank you very much.
Thank you.